Hi, and welcome to a call for discussion as healthcare providers to advance our abilities to support a most efficient process of rehabilitating postoperative shoulder patients. Today, with the support of 2 rotator cuff patients, I will provide both foundational principles to introduce an alternative approach to supporting your patient's recovery, and then a combined continuum of care case study over the course of these 2 patients' active assisted stages of postoperative recovery. Within this discussion, I hope to make a clinical contribution within a perspective that I think we all strive for. That of identifying the current impairment level that is limiting our patients from progressing, and then being able to pinpoint a truly therapeutic influence that they can most efficiently respond to. What I have recognized, however, despite our most careful evaluations and strategic implementations of our clinical knowledge and skills, is the human body at reflex speed will resort to neuromuscular substitutions at the first sign of fatigue or failure to the weakest link associated with movement production. We know what substitutions look like: pain avoidances, disuse atrophy, excessive use hypertrophy of the upper trap, levator scapula, and deltoid, hiking of the shoulder with elevations, and of course pathomechanics in the form of perpetuating subacromial impingement and resultant microtraumas, aggravating pain, and varying interferences associated with swelling. A more specific representation of our patients is we often have well-established pre-surgical physical impairments with respect to movement health recovery that continues to exist post-surgically. So we not only have a surgically repaired anatomy to nurture through the healing process, we also have to reintegrate the rotator cuff's critical role as a force couple and dynamic stabilizer within a myriad of potential comorbidities as previously mentioned. The impression I hope connects with you today and forever changes the way you practice going forward is that within one of the most dynamic joint systems of the body, especially in terms of functional capacity, is that the subtle details do in fact matter. And when you are able to deliver these subtle details, true healing can progress post-surgically. For Patty, we recognize what months of pre-surgical pain avoidances can accumulate in terms of both adaptive shortening and underlying motor inhibitions. Thus, as demonstrated through this sequence of active assistive motions, combined with detailed manual influences, was necessary to both resolve the remaining restrictive influences of mobility while simultaneously reestablishing the essential foundations of dynamic motor control. Within this familiar context, I am sure you have said at least once that you wish you had a third hand. This luxury is now available with the support of the UE Ranger. Recognize, as a result of the patient's motion being unimpeded concurrently as the therapist is integrating both combined graded mobilization techniques along with manual facilitation of appropriate motor activity. Thus, the patient's neuromuscular system is able to favorably adapt, gradually reducing the role of the therapist's influence as the patient regains her foundational requirements in terms of freedom of mobility and motor coordinations. Bridget, at 7 weeks post-surgery, despite the first impression of her ability to elevate her arm quite well with respect to this stage of recovery, what is revealed if one either looks closer or we were to ask Bridget to perform multiple elevations is in the reality the continued existence of a profoundly weak rotator cuff. As is often the case, with the exception of some post-traumatic repairs, there is usually on the part of the patient and their healthcare providers an attempt to exclusively heal with conservative efforts. Should this approach ultimately require a surgical repair, we can be confident that at a minimum there will not only be substantial weakness, but more specifically pathological weakness, meaning the presence of both muscular atrophy and varying degrees of neuromuscular inhibitions. Knowing pre-surgically each of our patients continue to require the use of their arms, impaired as they were, invariably is going to promote and retain substitutive muscle activity in the form of functional compensations. So if we are going to be capable of influencing the eventual resolution of muscular atrophy and the associated pathomechanics, we have to have the capacity to restore the loss of communications to the presently impaired tissues that cause the atrophy to develop in the first place. Therefore, in transitioning patients both in the earliest stages of active assistive range of motion and through their full recovery, we must, if we are desiring to produce the optimal results for our patients and referral sources, be capable of reaching and truly therapeutically influencing, or said differently, truly healing each patient at their specific impairment levels. This detailed intervention does not have to be either a whole new or difficult learning curve. You already have the clinical knowledge. You simply have to have the right tool to support the desired response within the varying impairment levels. To support greater foundation of the UE Ranger's clinical capacities versus the currently most established methods of rehabilitating the shoulder, I would also encourage you to view 2 videos available on our website, ueranger.com, titled UE Ranger versus Pendulums, and the second, UE Ranger versus Traditional Assistive Devices, where we offer discussion and validating research of how this process of supporting graded motor recovery can safely begin most efficiently in the passive stage of recovery, where critical foundations are established. At a minimum, this means you no longer have to teach your patients the difficult to perform pendulums, and more importantly, your patients have an effective means of supporting their full recovery. I am confident that you will be encouraged by what this means for you in supporting your manual skills in the passive stage of recovery. Just imagine the capacity to begin your manual influences with a relaxed patient having just warmed up with the UE Ranger versus flaring up their subtle yet powerful protective responses with either that of performing pendulums or riding the UBE, and the conflicting influences required by the active gripping as highlighted in the second video. Within the active assistive stage of recovery, 2 research studies have offered validating insight as supported both by the University of Kentucky, which demonstrated through EMG activity how these just mentioned actions of gripping that are required with traditional rigid bars such as brooms and golf clubs, as well as with pulleys, produces a conflicting response and therefore counterproductive influences when trying to restore necessary recoordinations within the full shoulder girdle. Then, a results-oriented study provided by Cincinnati Sports Medicine offers useful direction in how we can be most efficient for our patients in a quickly changing healthcare environment. Okay, let's return to applying this information. Within our efforts to support graded motor recovery, we encourage you to also grade the arcs of variable motions into small intervals of recovery in terms of both strengthening and endurances of both the intended tissue responses as well as gains in biomechanical recoveries. As just mentioned in the introduction of Bridget, whom was despite the appearance of a respectful ability to elevate her arm against gravity 7 weeks post-op, that in fact Bridget on a closer level reveals profound weakness with respect to the rotator cuff's ability to dynamically stabilize the shoulder during repetitions of variable movement demands. As captured within this exercise session of Bridget is a significant tremor of her distal upper extremity throughout this short arc of elevated reaching. While profound in severity, its cause, as determined through clinical reasoning, was linked to simple fatigue of her involved rotator cuff. If, however, we return in thought to the earlier mention that at the first sign of fatigue to the weakest link involved in the production of movement, the body at reflex speed should be resorting to compensations. If we look closer, while the fatigue is obvious, the absence of compensations is also apparent, and therefore the basis of my clinical reasoning that within our efforts to restore movement health, the subtle details provided by the UE Ranger versus traditional assistive methods are clinically significant. We have all heard the phrase, form follows function. In other words, your body will follow the message of greatest influence. It is my belief, therefore, in order to promote optimal healing, we must target the foundational impairment levels and in an appropriately supportive manner that the body can respond to, a therapeutic threshold, if you will. Within the foundational understanding provided by the EMG activity of the previously mentioned research, it is my belief, due in part to the muscular imbalances promoted by all tools requiring gripping, that the dominant message will be of the strongest muscles continuing to overpower an already impaired rotator cuff. Thus, in the act of a patient hoisting their arm with pulleys or a rigid bar potentially hundreds of times, will simply be biased towards the perpetuation of substitutive motor activity, deficiency of a force couple, and ongoing microtraumas as a result of subacromial impingement. As we return to Bridget's therapy session, we have found with the combined natural support of the UE Ranger within the currently identified therapeutic threshold that an appropriate overload can be delivered to the involved rotator cuff. What must be remembered is at this stage of recovery, the most recent capacity of producing motion occurred pre-surgically, of which most certainly included substitutive motor activity as a consequence of the underlying pathology. Thus, what is key to an optimal recovery is that we have the simultaneous capacity to both progressively recruit or grade the contribution of the rotator cuff, along with reintegrating its influences within the equally important recovery of healthy biomechanics. Within each session that you deem appropriate for your patients to reach a therapeutic level of fatigue, it is also possible, as demonstrated here by Bridget, utilizing the support of her non-involved upper extremity in promoting both a comfortable and therapeutic means of controlling the demands or appropriately cooling down. This capacity to provide optimal demands to the targeted healing tissues while simultaneously achieving avoidances of pain provocations, microtraumas to healing tissues, and ultimately via the promotion of oxygenated blood reaching the sites of ongoing healing has lasting carryover implications. As Bridget reduces further the demands on the fatiguing tissues, her neuromuscular system is provided a reinforcing ease in support of a progressive motor memory absent the promotion of future pain avoidances or regression to substitutions, and thus a carryover of intended movement productions. As a patient achieves the capacity to produce multiple sets of appropriate repetitions, you will recognize the appropriateness to advance a recovery into variable planes of new challenges and equal support of these anticipated next level accomplishments. Within these subtleties that the UE Ranger offers, the capacity to isolate portions of the rotator cuff are also possible. Demonstrated here, Bridget is isolating her supraspinatus muscle, and so what I have recognized with that particular muscle is I believe it acts as a great communicator, if you will. If it's inhibited, it almost gives direction or permission to the substitution muscles to engage. If it is reestablished, facilitated through this process, the substitutions have a direction to calm themselves. The key is to balance that message such that you can promote the dominance, or at least the influence of the supraspinatus and the external rotators to be on board when appropriate. And what often happens is that they fatigue, and if the task continues, then the dominance is reverted to the substitution muscles. And so the other value of the UE Ranger is you can integrate that message into a combined progression where facilitating the supraspinatus and then blending in with the external rotators is a capacity that I have found to consistently help to alter the all too common hiking of the shoulder, which the evidence of hiking, if a person continues to elevate, the rotator cuff is relatively inactive. So all you're promoting is strengthening of the substitutions. What we have found most helpful is for a patient who is demonstrating the propensity to hike or shrug their shoulders in pursuit of elevating their arm is to utilize the combined UE Ranger with the wall mount. As demonstrated here by both of our patients is the ability through the combined support of the weight of their arms and concurrent with the capacity to isolate the loading of their glenohumeral joint to achieve a facilitated amplification of their rotator cuff and thus support both a greater emphasis of the intended motor tissues while also supporting the resolution of the impingement-producing pathomechanics. We encourage you to begin this implementation at a point 5 to 10 degrees below their recognized substitutions. thus allowing both the resolution of the identified weakened contributions as well as traversing new challenges within the natural support of the UE Ranger. We recognize that traditional methods of supporting motion with pulleys and rigid bar emphasize the full available range of passive mobility. Based on the supporting research mentioned earlier, we strongly encourage you to trust the process of allowing your patients to regain ample strength and endurances within a given arc of progressive intervals of recovery prior to asking more of them in this particular context. To facilitate the capacity of your patients to support actions of their shoulder system through variable planes of spontaneous movements, it is encouraged, as Bridget demonstrates here, the ability to therapeutically integrate in a seamless transition the requirements of both multi-plane motor facilitation as well as the ability to impart influences of multi-plane integrative strengthening. As demonstrated here, Bridget is beginning to reintegrate the contributions from her lower extremities and abdominal core in supporting the progressions of higher levels of elevation. As she gains confidence in her kinetic chain control, she has the freedom with ample support to explore variable plane movement facilitations, much the same as required within her daily demands as a busy mother as well as a nurse. If it is recognized that a patient requires more specific influences of assisted muscle retraining exercises, the UE Ranger allows for such a targeted influence. As shown here in gravity-reduced applications of hook lying, the ability to enhance the role of the rotator cuff's influence of the force couple concurrently with promoting soft tissue allowances within the joint capsule. A further benefit is the promotion of rhythmic stabilization challenges by stabilizing the glenohumeral joint while concurrently promoting more distal impressions. If it is recognized that a patient fatigues rather quickly against gravity, the UE Ranger supports in side lying the capacity to work higher repetitions with a simultaneous ability to emphasize the role of the external rotators and still further with emphasis of the scapulothoracic contributions being promoted. Ultimately, the most complex motions will require similar supportive influences such as multi-plane functional internal rotation, which is a necessity of the all-important efficiencies of hygiene and dressing. As demonstrated by Bridget, the UE Ranger supports graded progressions which can ease this often uncomfortable portion of functional movement health recovery. As your patients conclude their rehabilitation, you can share in their joy of accomplishment, knowing both in appearance of movement but also in the underlying integrity that your patient has fully healed.
I've had a prior experience with physical therapy when I fractured my left arm. In that experience, it was a very painful experience with trying to get the range of motion done with that arm. I was kind of reluctant to come back to therapy when I had my arm fixed, and actually using the Ranger made the process a lot easier. It helped me get through this process and I think recover a lot quicker and have better range of motion by utilizing this tool. Again, with utilizing the Ranger, it helped with recovery. I had less pain when performing the exercises, which then encouraged me actually to perform them more often, and again, just speed up my recovery.
Allow the UE Ranger to optimally support your clinical knowledge and skills. Allow your enhanced abilities to reflect favorably on your clinic in terms of increased referral sources as a result of your ability to truly promote surgical healing towards optimal movement health recovery. Let us hear from you, as we are here to help.
We invite you to visit our website at ueranger.com, where you can find further resources to support using the UE Ranger with your patients. You'll be able to download a clinical manual and home exercise program, as well as view the supporting research and testimonials of both professionals and patients. We'd be happy to answer any questions you might have or discuss in more detail the features of the UE Ranger Movement Health System. Please call us at 402-210-8406 or email us at rehabinnovations@cox.net. We look forward to showing you how powerful the UE Ranger can be for your patients and your practice.